Good morning. Okay, so this morning, do you want to settle down? This morning we're going to go over the posterior trunk. Now, you'll be delighted to know that some of this we've already covered when we looked at the shoulder joint, but we can't talk about how you use your upper limb functionally from just looking at the glenohumeral joint and the muscles at the front of the arm, because hugely importantly is what's happening at the back. And just to remind you that the only thing that connects the upper limb to the skeleton from a mechanical point of view is the sternoclavicular joint. And think how powerful they are. Think of those gymnasts and what they do. And then the scapula is actually only attached through muscular and fascia. So we're going to be looking at that today. And we're going to be looking at what those muscles in the posterior back do and how they really are important for raising your arm above your head. Because pure abduction from a glenohumeral point of view only takes you to 90 degrees. So we do loads of stuff up here. So that's all to do with movement around the scapula on the ribs, on the thorax. So that's what we're going to be looking at. Okay, is everybody happy with that?
Yeah, I'm going to switch it. Sorry, because it affects our eyes. Like it actually weakens the muscles in the eyes. So.
Thank you. Is there research evidence for that?
I think it's difficult to see the board with the lights on.
Can't we dim? How about some and some? So what about the back ones? Okay.
Okay, is that okay for everybody? Okay, hands up if that isn't okay and you want the lights off further, bearing in mind that some people are struggling with the lights off.
Okay, that's lights. Okay.
I think this is fine.
Okay, guys, come on. Let's have the other view. Let's have the view that if we switch the lights off, who's going to complain?
If we switch the lights off, who's going to complain?
Come on, let's have a vote. Just have a vote. It's a free world.
It's not a little problem, I'm afraid. Is everyone okay with the lights like this?
It's got to be. They only had 2 people that want it on, and everybody else wants it off. Okay. Okay. You're meant to be looking here, and your laptop has got light, so you should be okay. Okay. And you. Okay. So this is what we're doing today. We're doing posterior trunk. Okay. I've just got to realise that some of these slides were made by an anatomist before me, and I realise it says 6, so I will get that changed to 7 because this is session 7. So the learning objective outcomes for today are we're looking at those major muscles in the upper back, the shoulder region. We're going to look at the movements, because that's hugely important, of the major muscles. We're going to look at the nervous innervation of those muscles. We're going to look at the review of the shoulder, which is going to be really nice. We're going to look at the intrinsic muscles, which are the smaller muscles of the back as well. Okay. And so that's the last bit's going to be a review. It's going to be really nice. So we thought that instead of going straight in, giving you loads of information, we'd give you like a little summary before we start. So we're going to talk about the posterior upper back muscles, so the large superficial muscles, and usually the larger muscles are involved with power and movement. And the smaller muscles are more often due to either little fine dexterous movements like the hand or control and stability. So we're going to look at rotation in a minute. We're going to look at, this is a right. We're going to look at rotation of the scapula on the chest wall. Okay. So we said that the deeper muscles, for example, the deeper muscles in the spine are more for spinal mobility, stability, and you have those erector spinae muscles and the splenius and the little segmental muscles that give you that erect posture and give you a stable spine. Okay, and lastly, we're going to just review all these rotator cuff muscles that we said stabilize the humeral head in the glenoid. Okay, so we're going to go back now. So we're looking at the back muscles. So they're organised into the superficial, intermediate and deep groups. So the superficial and intermediate groups are supplied by the anterior primary rami. Now, do you remember where we said anterior primary rami before in previous lectures? What about in the neck and shoulder? What nerves, what's up here? Yeah, they were all the anterior primary rami, wasn't they? C4, C5, C6, C7, T1. They were the anterior, supplying the large muscles and sensory system in the upper limb. So those are the anterior primary, big branches of, big branch coming out the spinal cord. Okay, and so the deeper muscles, so we've said they're deeper muscles which are going to be more to do with the spine, they're supplied by the posterior primary rami. And that's a much smaller branch, and that's due to sort of embryology and development. And they're more related to movement of the spine and stability of the vertebral column. So this is looking at the spine. Oh, I have my pointer. Okay, so we know that this is the front, and this is the back, posterior. So this is the big vertebral column, and we're just showing you here, this is the spinal cord running through, and you can see these layers that the spinal cord is surrounded by, and they're called the meninges, and they're split up into different branches, the dura, the arachnoid, and the pia mater. But you'll go in much more detail when you do your neurological module for that. And it's a membrane that surrounds the spinal cord. Okay, so the anterior primary rami we said was this one, which is the thick root that we said is going to supply these posterior shoulder muscles. And the posterior primary, much smaller, this little branch here, going in and supplying the deep muscles. Okay, so we have the extrinsic, the superior muscles, posterior axio-appendicular, that attach the upper limb to the thorax and the arm. Okay, and then you've got the intermediate ones, which are not so vital, but they're to do with respiration. And then we've got the deep. Does this go this way? Yeah, the deep muscles, which are to do with stability. So you've seen this sort of picture before. So we've talked a little bit about some of these muscles. Do you remember the last time we did the shoulder? But they're very important. So you've got these three different groups. You've got trapezius, this massive muscle here. This side, it's been moved to deeper muscle. So trapezius is both sides, obviously. So these are the upper fibers right up to the top of the nuchal line. Okay, coming right down here to the spine of the scapula, and all the way down to about T7, T12. Okay. Then lat dorsis, massive muscle here, attaching onto the medial humerus. Very important. Shoulder, we're going to talk about that in a minute. Then the deeper group here, we're going to talk about levator scapulae, this little muscle here, that often becomes tight with neck pain. If you do a lot of studying with the head forward, that often becomes very tight. Then you have your rhomboids here, rhombus major and minor. And then we're going to talk about the scapulothoracic group, which are all these rotator cuff, teres major here, and deltoid, which we've talked about before, which is supplied by which nerve? Yay! Perfect. Okay, so we do talk, this is trapezius, this massive muscle, and they don't need you to know the fine detail of it. They want you to look at the fibers and where they're going. So these are going up here. So if they shorten, they're going to tension here. So they're going to pull the glenoid upwards, and the middle fibers are going to retract, and the lower fibers are going to depress the scapula. So that's what you need to know. So it's very important for this scapulothoracic joint. It's trapezius. It's supplied by the accessory nerve. Okay, so we're going to look at rotation of the scapula, which we talked about just a second ago. So if we look at, this is your right shoulder, so this is at the back, yeah? So So we said that 0 to 20 is supraspinatus in terms of abduction, and to 90 is deltoid. But in order for the arm to get above the head, the shoulder girdle must rotate. So trapezius rotates the glenoid upwards, and serratus anterior, which we've talked about before, which is attached to the ribs, is going to bring it round, because we said it hugs the scapula. Can you see that? So 0 to 20 is supraspinatus, initiate abduction. Then we're going to 90 degrees abduction. In order to get above your head, you have to slightly exterior rotate, but it's a lot of movement. And if you get hold of each other and you grab hold of that inferior angle and you get somebody to move, you'll see that it ends up here. It's very important. So it's very important for rotation. You can look at how the arm is lowered as well. Sorry, I've lost my pointer. So scapular rotation is that key for movement of the upper limb. Right, so then we're going to look at latissimus dorsi, which is this large muscle here. Look how low down it goes. And it's very highly supplied. If you remember that brachial plexus, that thoracodorsal nerve came up really high. So in terms of trauma, spinal injury and stuff, I used to work on the spinal unit, Stoke Mandeville, and used to work a lot with trauma. And if you're going to keep that muscle working, because it's if you're a T1 or something, for example, or T2 injury, so you fractured T2 and injured your spinal cord, you're still going to have this muscle working. It's very important in stability, in sitting, and being able to do lifts and transfers. And what it does is if you fix the shoulder and it shortens, you can see that it will lift the pelvis. But otherwise, if the pelvis is fixed, it will pull down. So it extends and it adducts. And it's very important in things like climbers, going up the mountain, swimmers, also slightly medial rotates, because it's attached to this intertubercular groove, bicipital groove. Very important muscle is lat dorsi. And what do we say about the axilla? Where is it in the axilla? Can anybody remember? Posterior wall. Massive muscle. Posterior wall axilla. So that's really good. Well done. Okay, so you can see how it's sort of fitting together a little bit. Levator scapula is just a little annoying muscle that really becomes painful when you get neck pain. It gets really wound up by, and you can see it's very near sort of C7, T1, which is a very common site of neck pain. Students bending over, getting stressed, all these muscles get really tight. Neck trauma, old people like me that get degenerative changes, levator scapula tends to get very tight, and it inserts onto this medial border of the scapula. So that will obviously elevate your scapula, and you can see that when you're stressed, your shoulders come up like this. Okay, and it also slightly rotates this upper end by depressing the glenoid. So that's levator scap. So then we'll talk about the deep groups. This is hang on a minute. The rhomboid. Sorry, yeah. So rhomboid major comes from the spinous process of T2 to 5, and minor comes from C7 to T1, so it's slightly lower, and from the ligaments nuta, and it retracts the scapula. So you can see these muscles here. They often become really tight as well, and it brings the scapula backwards, and it depresses the shoulder. So there we see the superficial ones, and then we have the deeper ones. So trapezius elevates, supplied by the accessory nerve, lat dorsi by the thoracodorsal nerve. And you can see this fascial and tendinous insertion. We've got levator scapulae, which is a dorsal scap nerve, the two rhomboids, and then we've got teres major, which we're going to talk about in a second. And that comes from, teres minor is there. Do you remember it was one of those stabilizing muscles for the on sit that attaches onto the greater tuberosity. This is teres major, and that adducts and medially rotates. So it's very similar position from this lower border of the scapula. Now, this wasn't actually included in the slide on this talk, but I think we can't talk about movement of the scapula without remembering that serratus anterior here, you know, attaching onto the ribs, holding that inferior angle in, and obviously when it doesn't work, it wings. So we just said that when we lift your arm above your head, serratus anterior is pulling that medial border. So it's very important for scapular stability. Okay, and we remember deltoid. We've done deltoid, so that's nice and easy. So it attaches to the lateral clavicle, acromion, the spine of the scapula. It's quite a big muscle. You can see when it's wasted in trauma or injury. It's supplied by the axillary nerve. What else supplies the axillary nerve? Can you remember? It supplied teres minor, didn't it? And if you have damage to the axillary nerve, you got that regimental badge. And we talked about that with anterior shoulder dislocation, and we talked about that with superior, surgical neck fractures. So that's deltoid. Okay, good. How are you doing so far? You okay? It's quite nice to put it all together. Sort of makes a bit more sense. So we're going to talk about the, scapulothoracic group. This is teres major. So this muscle here, it's an internal rotator and it extends the arm. It's not a huge muscle, but it's just part of this group. It's just important to know about it, really. Inferior suprascapular nerve coming onto that medial border of the humerus. And we all know about the rotator cuff because we did it in the shoulder, but it's lovely to go over it again. So this is the posterior view, just remembering of the rotator cuff. So we have here supraspinatus in the supraspinous fossa. And where does it insert? SIT, yeah? SIT, supraspinatus, greater tuberosity here. So this is your cuff. They all blend together and they blend onto the head of the humerus and they give you that stabilizing effect. Good. And we said that it can become impinged a little bit and on that arch if it gets inflamed, and you can get this painful arc. Then we talked about infraspinatus, which is this muscle here from the infraspinous fossa, same insertion. Same nerve supply as supraspinatus, the suprascapular nerve. And teres minor, which we said just a minute ago, which you quite rightly said, was the axillary nerve along with deltoid. So those are the SIT. And there's one more rotator cuff. Can you remember what that is? Perfect. So this is subscapularis. This is the other way around, obviously. So this is the subscapular fossa anteriorly here. It attaches on the lesser tuberosity. So it's giving you that frontal stability. And do you remember we had that, there was an anatomy dissection of the brachial plexus. And we saw that the brachial plexus is coming down under that clavicle and then it came down here, didn't it? But you could see that at the back of that was subscap. There's a slide. So that's supplied by the upper and lower subscapular. So that gives you that stabilizing effect of the shoulder. And the posterior muscles are giving you that motion of the scapula. Okay, so this is put them all together, which is quite nice. Infraspinatus, supraspinatus, teres minor. Okay, so this recaps the scapulothoracic group, the rotator cuff, which we all realise. So we said here again that supraspinatus says 0 to 15, roughly, of abduction supplied by the suprascapular. So you can see that if it shortens, it's going to pull, because it attaches onto that, it's going to pull that way. So infraspinatus, teres minor, infraspinatus here, teres minor, adducts, and that lateral rotates because it's inserted slightly posterior, so it's going to pull backwards, and subscap, which slightly medial rotates because it's more at the front. And they're really important, and very commonly you get rotator cuff dysfunction. So either because it has when it attaches onto the head of the humerus, you've got this sort of tendinous cuff, and it has a very poor blood supply, and it's very easy to get tears and degenerative changes, and then you get pain, particularly somebody of my age. It's not so common to get tears and degenerative change in your age, but you can get nasty skiing injuries where you land on your arm and you can rip the cuff. If it's a big tear, then at your age you'd have it repaired, surgically repaired. Okay, so that was quite nice going through that. So this is clinically, from a musculoskeletal physio point of view, we don't talk about serratus posterior so much because it's more involved with respiration. So you can see it's a small, deep muscle. It's in the intermediate group. It's still anterior primary rami, like the superficial ones. And you've got the superior serratus posterior and the inferior. And they're just involved with helping in respiration. So you might like to remember them when you do your respiratory module. We have respiratory therapists who specialise in respiratory medicine, but it's not my field. So, the intrinsic. What do we say about intrinsics? Can anybody remember? Small. So intrinsics are the hand, they start and finish in the hand. So intrinsics in the back, start and finish in the back. So, oh, sorry, wrong pointer. So they run all the way along the spine. And they're very important for stabilising the spine. The spine actually is very stable. It's not flopping about, and one vertebra doesn't pop in and out of the other. And erector spinae, so these muscles here are very important. Longissimus, iliocostalus, and spinalis. So they run the length of the spine to give a lot of stability. And then you have some shorter segmental muscles, things like multifidus, that give you, if you imagine your spine is loaded, they go in between each segment and they give you that spinal stability. And they tend to get affected by pain. So, and then you've got, up the top, you've got the suboccipital and the splenius, these long muscles up here. So they're very important for stability. Okay, so we're going to look at revision of the shoulder. So, revision of the shoulder. So it's we said right at the beginning, didn't we, that it's inherently unstable. Why? Go on, say that a bit louder. Why do you think it's unstable inherently? Because of the anatomy, because of the bones? Yeah. So the glenoid is small and the head of the humerus is large. Okay, so it it allows huge biplanar movements. It doesn't have any inherent stability compared to the hip. And it's got quite a lax capsule, particularly anteriorly, which we said makes it a bit vulnerable for dislocation. So can you remember what we said it's stabilised by? Shout it out. Rotator cuff, hugely important. The ligaments, absolutely. The muscles, and obviously bigger muscles, and you've got intra and extracapsular ligaments and the capsule, so that it all binds it down together. So this was just a recap slide that I just put in for your reference, really. It just gives you a very clear reminder of what the muscles are and what the nerve supplies are, so you can go back to it. And just look at them, they're all mostly C5, C6. So we think of the brachial plexus we go back to that we did. Okay. So just to summarise, the shoulder joint is very mobile. It's got the greatest amount of movement in all the joints of your body. It's relatively unstable. We don't in this room, how many people have dislocated their shoulder? There must be somebody. No? Oh, it's not that rare, but it's fairly rare. So, think about the movement that we have. It's relatively uncommon. Stability is largely formed by those lovely rotator cuff muscles, supraspinatus, infraspinatus, teres minor, subscap. And we said that it's weakest inferiorly, which is due to sort of a bit of laxity in the capsule. And it's slightly more vulnerable when the arm is out. So if you think of rugby and things like that, when you've got someone ploughing into you, and abduction and external rotation it tends to be a movement where you can dislocate shoulder. I had a patient last week, I thought of you in my clinic. I had this young girl who had previously dislocated her shoulder. And once you have dislocated your shoulder once, the chances of you doing it again are very high. So she actually only just stretched. She was in abduction, external rotation, and her shoulder popped out. So she may be going towards having some surgical intervention. You can't keep having your shoulder pop out, and also it's very painful. And what did I test for? What did I test for that could damage anterior? Yeah, axillary nerve. So that was I checked for deltoid, and sensation on the lateral side, and she was fine. Okay, and obviously with fractures and things, dislocations, this circumflex humeral artery that winds around the top. So that's a reminder. We talked a little bit today about that painful arc where the cuff is getting irritated underneath this archer bone, which is called what? Chromion. Yeah, good. And obviously the other thing you can get with shoulder is this separation. Because the clavicle has such a supportive role, you can get separation of the shoulder, can't you? Landing on the shoulder, and therefore you damage these ligaments, the conoid and trapezoid ligaments, and the shoulder tend to shoot upwards. Oh, hang on, I've got a bit connected here. So that's the AC joint, quite common in rugby players, footballers, people like that. Okay, was that helpful to go over a little bit of the shoulder and put it all together? So you can't think of movement at the shoulder without looking at the back. And I must emphasize, when you look at patients clinically, please look at what's happening at the back or where there's any trick movements, because it will tell you a lot.